Good morning, everybody. On behalf of the organizing committee, I welcome you all for this interesting CME on cardio-diabetology. All of us know medical science is a rapidly advancing field, where yesterday's fact may become matter for the archives to store, and today's fact may not find agreement with experts of tomorrow. Continuing medical education is therefore an integral part of medical profession. Today's program will cover several issues on cardio-diabetology, and they will be addressed by a galaxy of speakers of national and international repute. I request all the delegates to post their questions in the chat box, and I'm sure the proceedings of the conference will contribute immensely towards better patient care.
I've got opportunity to introduce Dr. C Manoria, who is a living legend in the field of cardiology. Dr. C Manoria is a well-known cardiologist in our Madhya Pradesh as well as in our country. He has been having the head of the department of the cardiology in the Gandhi Medical College in the past. Then subsequently, he has attained the greatest position in various cardiological societies like Cardiological Society of India, Indian College of Cardiology, Asia Pacific Society of Cardiology, and so on. He has received several awards and orations by Bharat Ratna, Honorable Shri APJ Abdul Kalam, and other awards like this Best Cardiologist Award in Madhya Pradesh. He has organized World Congress on Cardiology. He has written and edited 33 books and published so many publications and delivered more than 600 lectures. I will invite Dr. C Manoria on a very burning topic, the recommendation for lipid lowering therapy in a very high risk patient with contest to acute coronary syndrome. I will request Dr. Manoria, please deliver your lecture.
Good morning, everybody. For the next 18 minutes, I'll be talking on this upcoming topic, recommendations for lipid-lowering therapy in very high-risk patients of ACS. All of us know acute coronary syndrome results from disruption of a vulval plaque with superimposed thrombus formation, resulting in occlusion of the culprit artery. If the culprit artery is subtotally occluded, this results in unstable angina or non-STEMI, and if it is totally occluded, this produces STEMI. Although ACS manifests as a thrombotic episodes, the underlying initiating culprit is LDL cholesterol, and unless this is targeted, the outcome cannot be optimized. We have a panoply of strategies to manage ACS, antithrombotics, PCI, pharmacoinvasive, and several other strategies, as you can see on the slide, but lipid modulation is an integral part of management of ACS. It is also very important to remember that the treatment of culprit artery lesion by an interventional cardiologist is not self-sufficient for holistic management of ACS. Following a successful PCI and stenting of the culprit lesion, approximately 12% of patients develop MACE from a non-culprit artery lesion during their 3 years follow-up. The risk of recurrent ischemic events, don't forget, is maximum in the first 30 days, and therefore all possible strategies should be utilized during this period. Lipid modulation targets both the culprit as well as the non-culprit lesion and improves acute as well as the long-term outcome of ACS. Rather, it is mandatory throughout the history or throughout the course of acute coronary syndrome. Now, there are 3 issues in lipid management in ACS. First, you have to categorize the ASCVD risk of the patient and then choose the target for him and then try to reach the target by drugs. Now, this is ESCA, EAS and AHA-ACC guideline. The very high risk in ESC is documented ASCVD in any of the territory, diabetes with target organ damage, or at least 3 major risk factors, or early onset type 1 diabetes of more than 20 years, severe CKD score more than 10, and FH with ASCVD or with another risk factors, while polyvascular disease is a criteria in AHA-ACC risk for the very high risk group. And the targets are less than 55 in the very high risk with the ESC and less than 70 in the ACC guideline. But the Lipid Association of India Expert Consensus 2020 had made a new category of extreme high risk. Now, this shows the memory lane of LDL targets from 1988 to 2020. And as you can see, the LDL targets are being sliced down slowly and slowly. And according to the Lipid Association of India, the extreme risk category A, the LDL target is less than 50 with an optional goal of 30, and category B, less than 30. So what is the meaning of this extreme category, category A and category B? Category A means that you have a CAD with greater than 1 feature of high risk group, that is more than 3 major ASCVD risk factors, 2 major ASCVD risk factors with greater than moderate risk for unconventional risk factors, or greater than other high risk features. And category B means you have a polyvascular disease, you have ACS occurring even when your LDL level is less than 50, and more than 1 feature of a very high risk group, which means a pre-existing ASCVD or diabetes with 2 other major ASCVD risk factors or FH. Now, what was the necessity of creating this extreme risk group by the Lipid Association of India? Now, when we look at the IMPROVE trial, 32% of patients in IMPROVE trial continue to have events with LDL 53, and 12.5% in the ODC trial continue to have events despite low LDL. So the question arises, what are the characteristics of these patients who continue to have cardiovascular event despite very low LDL levels? And if we look at the TIMI risk score for secondary prevention, you can see these are the 9 risk factors. And when we apply these 9 risk factors, I'll show you for the IMPROVE trial what would be the results. But what is important is that if the risk is, these risk factors are 0, the 3-year mortality is only 3.5%, but all the 7 risk factors are present, the mortality mounts up to 58%. So when we apply this TIMI risk score to the IMPROVE trial, you can see the low risk category is when there's only 1 risk factor, the intermediate risk is 2, and the high is 3 or more than 3. In the low risk factor, you can see only 14% develop CV events. In the intermediate risk, 19% develop CV events, and in the high risk, as much as 34% develop cardiovascular events. And the greatest benefit is seen in the high risk group, about 6.3%. In the intermediate risk, you can see 2.2% with NNT 46, and in the low risk group, 0.9% with NNT 111. In the highest risk, the NNT was only 16. When we categorize patient according to the vascular bed in the ODC outcome trial, you can see in patient with disease in the 3 vascular bed, 26.7% develop vascular events. In 2 vascular territory, 20.3%, and in 1 vascular territory, only 8.6 develop vascular event. And the greatest benefit is in the 3 vascular bed, about 13% absolute risk reduction. So based on this, the Lipid Association of India 2020 categorized this extreme high risk group with the LDL target of less than 50 for the category A of the extreme high risk group, and for the category B, less than 30. And we can achieve these targets by statins, ezetimibe, and the PCSK9 monoclonal antibody. The strategy is usually to first have statins, gold not achieve ezetimibe, and then PCSK9 inhibitors. Lower is the LDL levels, more is the benefit. But while we are targeting LDL cholesterol, you must be very clear about the nuances of LDL. And the first thing you should be very clear is LDL has a causal relationship with the ASCVD. It is the primary target, and non-HDL is the secondary target. The first issue is lowering of LDL is very, very safe. These side effects which are encountered during lowering of LDL are not at all related to lowering of LDL. They are related to the drug. So if you come across diabetogenicity, you come across muscle side effects, they are not related to LDL lowering. They are related to the drug. Other thing is patient with double loss of function mutation PCSK9, they have very low LDL, 14, 15, 16. They are totally healthy, fertile, no cognitive decline. And if you look at the data of the 4-year trial, 2% patients have LDL less than 10, ODC 7.5% has LDL 15 and improved at 6% as 30, but no side effects were noted. So the first big message is, don't be scared of lowering LDL to very low levels. It is very, very safe and provides a lot of benefit. This is the data of loss of function mutation of PCSK9. You can see LDL 15, LDL 14, and all these individuals are very healthy, fertile, with good cognitive function. The other thing you must remember is that the LDL in the blood do not cross the blood-brain barrier, and the brain cells are capable of manufacturing their LDL for their function. So that should not be the issue. And here, as you can see, LDL levels lowered even up to 20 is very, very safe. The other thing is, in the statin era, we had the dicta, LDL, lower is better. In the PCSK9 era, we had dicta, super low LDL is better than lower LDL. And the correct dicta is LDL, lowest is best, lowest is best, as shown by the PCSK9 trials. The other nuance you must remember is, start lowering of LDL at the earliest, treat aggressively, and produce sustained lowering to avoid the harms of cumulative exposure. And here you can see classically illustrated in FH that if you initiate LDL lowering therapy at a later date, the threshold for CHD decreases. If you initiate at an early, the threshold for CHD is dramatically changed. The other thing to remember, particularly in diabetic patients and in metabolic syndrome, is that patients with similar LDL levels can have different number of LDL particles and therefore different pathogenicity. Here you can see both these patients, LDL 130, but look at the non-HDL, which reflects the LDL particles, 148 in one and 180 in another. The other issue you have to remember is that if the baseline LDL is above 100, it decreases mortality, provides mortality benefit as is shown by statin trial. But if the baseline LDL is below 100, it only produces reduction in cardiovascular events as shown by the PCSK9 trials. And the big issue is, if you want to arrest the progression of atherosclerosis, you have to slice down LDL to 65 or 60. And if you want regression of atherosclerosis, the LDL has to be sliced down to 50 or less than 50. And this is beautifully shown by both these trials. The reversal trial shows that we can arrest the progression of disease, and the GLOVE trial with the on the right side of the screen showed that you can regress atherosclerosis. And in the statin era, we've already seen that statins are powered to decrease LDL by 1 millimole, and this translates into reduction of cardiovascular events by 20 to 24%, as shown by the CTT and meta-analysis, irrespective of the baseline LDL. Even if you initiate statin at very low LDL, as you can see here, the benefit is nearly same. And statins, no doubt, are very, very safe drugs. So what are the multifaceted actions of statins? Statins, they improve endothelial function, they decrease LDL and delipidates the plaque, which can be beautifully seen by vascular MRI. This is before statins and this is after statin. You can see the plaques are delipidified. Any therapy which delipidates the plaques will improve outcomes. And the same was shown in the yellow trial, that you can see the lipid core burden index is decreased after a few weeks of statin therapy. The hot plaques, the vulnerable plaques are hot plaques. And if you use statins, this is a PET CT showing a hot plaque. If you use statins in these patients, this plaque is passivated and you can see the change on the repeat PET CT. They also promote calcification of the plaque, stabilize the plaque, decreases cardiovascular event. And the big message coming from here is that if the patient is taking statin, do not use calcium scoring. It is going to be fallacious. And they have a panoply of pleiotropic effects, as you can see on the screen. And what is not often publicized is that the statins decrease thrombogenicity of the blood. So in the event of a plaque rupture, the probability of developing an acute coronary syndrome would be increased if your thrombogenicity of blood is more. 1 out of 10 plaques only culminate into an acute coronary event, and because statin decrease thrombogenicity of the blood, the probability will be minimized. And when you are targeting these patients, don't only look at the vulnerable plaque, you also look at the vulnerable blood and the vulnerable myocardium. And what is also very, very important, statins produce a legacy effect. You take statins for 5 years as shown in the Boscov and enjoy the legacy benefit for the next 20 years. You can see here, CHD mortality, all-cause mortality, revascularization, heart failure, all showed a statistically significant reduction after 20 years. In ACS patient, this is the miracle trial, and statins high intensity were initiated 24 to 96 hours of onset of ACS, and you can see a statistically significant reduction in the ischemic endpoints, a 16% reduction, and worsening angina with new objective reason of ischemia requiring urgent rehospitalization was also decreased significantly. And the Prove It trial also showed a 16% reduction in the ischemic endpoint, PRAVA 40 versus the TORVA. And the EuroHeart study again showed that the all-cause mortality at 7 days was significantly lower in group receiving early statin therapy. And this is the Armada ACS. If you use peri-procedural atorvastatin, you can decrease the MACE and peri-procedural MI. And this is the subgroup analysis of Prove It. TB20 again shows MACE can be decreased by statin, TBR and non-TBR can also be. The yellow trial I've already showed you. And these are the pleiotropic effects of statins. So statin is a class 1A indication for all patients of ACS. It should be initiated right at the onset of acute coronary syndrome. And statins, as we've already talked, they produce multiple beneficial effects. They modify the plaques, and if you will bring LDL to lower level, they can arrest progression of atherosclerosis and even regress atherosclerosis. So these are the utility of statins, which we have already talked about. They must be initiated right at the onset. High intensity statins, greater benefits in STEMI compared to non-STEMI, and they must be given 1A therapy. If the goals are not achieved, you can add ezetimibe, as was shown in the Improve IT trial, showed LDL lowering of 53 compared to 69, a 10% reduction in the primary endpoint, and you can see non-fatal MI reduced, non-fatal stroke reduced, revascularization. The benefit was particularly seen in diabetic patients, and this is a precise IVUS with ezetimibe showed regression. Now, if your goals cannot be achieved with statins, again, we use ezetimibe, and this is a 1B indication. PCSK9 are the wonder molecules which have revolutionized the treatment of lipid management in ACS and other subsets. All of us know how does PCSK9 acts. The normal function of PCSK9, this blue one is PCSK9, is to bind to the LDL particle and LDL receptor. The LDL receptors, the LDL particle is cleared in the hepatic cells, and the LDL receptors undergoes lysosomal degradation and cannot be recycled. Their number decreases, and therefore LDL levels increases. But if you block the PCSK9 with PCSK9 monoclonal antibodies, then the LDL receptors are free to bind to this particle, taken inside the hepatic cell, LDL is cleared, the receptor is recycled again and again, and that increases the number of LDL receptors and more cholesterol is lowered. PCSK9 are no doubt more powerful than statins. They decrease LDL by 60% or 65%. And what is very interesting is they favorably modify all the components of lipids. ApoB decreased by 45 to 55%, LPA 25 to 35, VLDL 30%, and HDL is also elevated 5 to 9%. This is the 4-year trial. All of us are aware of it. A secondary prevention trial in patients with stable coronary artery disease, and the ischemic endpoint reduced by 15%. But as I already told you in the earlier part, no change in the mortality. And this is the primary endpoint. The curve takes about 6 to 8 months to separate. And more qualifying MI, less than 2 years, the benefit is more, as you can see on the left compared to the right. If there are more than 2 prior MIs, more benefit on the left compared to the right. And if you have multi-vessel disease, more benefit than no multivessel disease. Lower is the LDL cholesterol, more is the benefit we've already talked about. And this is the ODCE outcome trial. Post ACS, mind you, the patient was enrolled 1 to 12 months after ACS. What is very, very important to realize is that even when you use PCSK9, the curves in ACS start separating after 1 year. And this should always be remembered. And as we said, PCSK9 trials have not shown reduction in mortality, but the baseline LDL was less than 100. But if you analyze later the ODCE with LDL more than 100, there was a reduction in the all-cause mortality. This is the AVOPEX trial, which initiated statin during the hospitalization phase. It was not powered to determine the outcome, but showed that LDL can be substantially reduced here, 77%, and has good safety. So statins can be initiated. This is a Japanese trial, again, AVOPEX. You can see RCT in this Japanese patient receiving pitavastatin and patient going for PCI. Substantial number is receiving goals, LDL less than 70 and even less than 35. And this is another AVOPEX trial in STEMI, non-STEMI patients undergoing PCI. Again, you can see substantial benefit. The guidelines recommend statins as the initiating therapy. If goals are not achieved, wait for 4 to 6, initiate ezetimibe. Goals not achieved, wait for 4 to 6 weeks and initiate PCSK9. But the problem is, as I already showed you, the curve starts separating after 1 year. If you waste 4 to 6 weeks after statin, 4 to 6 weeks after ezetimibe, you are getting benefit after 15 months when the maximum incidence of recurrent events is in the first 30 days or in the first year. And therefore, although the guidelines recommend this, but if you are coming across patients who have a very high risk of, they should be initiated right at the onset of ACS, although there could be difference of opinion. So patient with multivessel disease who will have more ACS, more infarcts, more recurrent revascularization, even CABG, recurrent MI, again, you will have more revascularization, stenting, CABG, post-CABG stenting, young patients who have recurrent events in the long run, polyvascular disease, raised FOB, raised LPA, FH, all these are very, very high risk patients, and PCSK9 should be initiated at the earliest rather than waiting 6 weeks after statin and 6 weeks after ezetimibe. These are the beneficial effects we've already talked about. Inclisiran, the beauty of inclisiran is that a single dose, 300 milligram, decreases LDL by 50%, and this remains there for 6 months. Although inclisiran has not been tested in ACS, has been tested in ACD, but I'm sure in times to come, they will be tested in this subset of patients. So what are our achievements? Moderate intensity statin, you can slash down LDL by 30%, high intensity statin 50%, high intensity plus ezetimibe 65%, PCSK9 60%, PCSK9 inhibitor plus high intensity 75%, and all 3 drugs by 85%. So we are powered with very effective drugs which can reduce LDL cholesterol to very low levels. So what are our achievement of war against lipid with these new weapons in the high-risk ACS? When we talk of the issue of can we stabilize the plaque, the answer is universally yes. Yes, statins alone are powerful in this. Can we reduce the build-up plaque, that is arrest of progression of atherosclerosis? The answer is again universally yes, and has been elegantly shown by the reversal trial. And when we talk of can we shrink atherosclerosis plaque, that is regression of atherosclerosis, the answer is universally yes, as beautifully shown by the glove. But when we talk of the issue, can we make the plaque disappear from the vessel wall? This is a big unanswered question to be resolved in future. But at the moment, the answer to this question is no. So in summary, ACS has a very high morbidity and mortality, and the risk of recurrent ischemic event is highest in the first 30 days. All strategies must be utilized early in ACS to have the maximum benefit. Besides antithrombotic therapies and PCI, lipid modulation is an integral part of treatment throughout the history or throughout the course of acute coronary syndrome. LDL targets depend on the category of the risk, and the patient, and LDL lowering should be initiated at the earliest, and even very low LDL 10, 20 are very, very safe. And LDL target should be reached at the earliest in the extreme high risk group, which I've shown by high intensity statins, ezetimibe, and PCSK9, and RCTs with outcome data required in ACS, because we don't have RCTs in the in-hospital phase. The ODCE has after 1 month, right at the time of admission. Thank you very much for your kind attention.
Thank you, Manoria sir, for your enlightening speech. Sir, one
Very
question
much.
from my side. How to manage dyslipidemia in pregnancy?
If you have dyslipidemia and pregnancy, you can use resins, other drugs, and lifestyle modification. If it is a case of FH, you can resort to LDL apheresis also. Mepomycin, although not widely used except in FH, has been granted category B, although they are, which means there are no any trials. Resin is the best answer together with lifestyle modification, and if you have FH, you can resort to LDL therapy if the LDLs are very high.
Dr. Manoria, this is Dr. Asha Murthy from Chennai. Good afternoon, sir. It was such an excellent presentation and such a difficult topic you had covered and precised in a very 18 minutes. Again, covering all the studies. I think we had a brief of very good presentation. I just wanted to know that what is the role of pitavastatin in dyslipidemia? Because we are not using pitavastatin in a practical day-to-day practice. Mostly we are using statins, Rosva, atorvastatin, escitalopram, and pitavastatin has not come into a role, or sarcoglycan also we are not using it. So what is your clinical experience regarding this utility of this drug?
Pitavastatin is a moderate intensity statin, and its specific indications are if you have a patient with statin intolerance, you can use pitavastatin 2 milligrams with ezetimibe will be a very useful combination. It does not have diabetogenicity, as has been shown in a trial that if you initiate pitavastatin in IGT, the diabetogenicity is not there. And thirdly, it is also safe in CKD patient. It has been shown to increase the eGFR compared to rosuvastatin, which has an adverse effect in CKD. Atorvastatin is also safe.
Dr. Manoria, I have got question that what is the current status of LPA, and also you tell the what is the evanucumab, which is approved by US FDA or not? What is the current status of the LPA?
LPA, all of us know, is genetically determined. It not only has an atherogenic potential, it also has a thrombogenic potential. That's why PCSK9 studies, which has elevated LPA, has shown decrease in VTE also. The higher the level of LPA, more is atherogenicity, lower is the level of LPA, less is the atherogenicity. Nicotinic acid decreases LPA, but this is not available. PCSK9 decreases LPA by 25%. The Horizon trial is ongoing with antisense agent against ApoA of LPA to see whether lowering of LPA without changing the LDL levels would benefit. The results are going to be out in 2020 and 24. And if the trial comes out to be positive, then only we will have an evidence-based recommendation for LPA. At the moment, the recommendation for LPA is an expert opinion and not an evidence-based, and do not have an evidence-based target for LPA. Regarding your question of evanucumab, it is an angiopeptin-like 3 antisense agent, which is approved by US FDA early this year. And it is very useful for homozygous familial hyperlipidemia because it is action is independent of the LDL receptors. All of us know in FH, homozygous LDL receptors are not active. So even if the LDL receptor activity is very less, this drug is effective, and this is the beauty of this drug.
Lastly, I want to ask, do PCSK9 have the legacy effect, PCSK9 inhibitors?
Statins have legacy effect. There's no data as such for the legacy effects of PCSK9, but it is possible after a few years this data may be analyzed. But at the moment, no such data.
Dr. Manoria, this PCSK9 inhibitors, which has a role in venous thromboembolism. Does it have any role or any trial was done?
I told you PCSK9 because it decreases LPA. The follow-up of the PCSK9 trials have shown that VTE was decreased only in those subset of patients whose LPA was elevated. Okay. And the explanation is obvious because LPA not only has an atherogenic potential, it also has a thrombogenic potential. So that's why the reasons. So it has a role in VTE, and in future you may have separate trials to test PCSK9 in patients with VTE. But
Now,
at the moment, no dedicated trial.
now we stop the discussion, and thank you very much, Dr. C Manoria, who has given a very lucid and informative talk about the lipid lowering agent in the high risk patients of the dyslipidemia. Now we will move